that studies demonstrated that the level of amputation is inversely proportional to the degree of independent living after surgery. And there are so many factors associated with the outcome of lower limb amputations and their healing, including smoking, anemia, malnutrition, previous vascular surgery, of course, the presence or absence of a pulse, and antibiotics, trauma, and other vascular parameters like the ABI, the duplex, and the angiographic findings. In this review here, or the meta-analysis actually, Penn Barwell mentioned that there was progressive and significant worsening outcomes as amputation becomes higher from below knee to trans knee or above knee. A significantly greater proportion of patients with a below knee or a trans knee amputation were able to walk 500 meters than those with an above knee. So it's obvious that we need to have a lower amputation level. Since the 50s, this old article here mentioned the advantages of the below knee amputation. It's هو في حادثة لخبطة في اللون الأصفر يعني بس anyway الريهابيليتيشن بتاعتها is twice as likely and mortality is significantly lower, but there is increased incidence of poor wound healing with subsequent revisions. Dormandi et al. Mentioned that in a prospective study of 700 patients in 51 centers in 6 European countries, there was an incidence of 19% of revisions of below knee amputations. And O'Dwyer, I think this is the most famous article about below knee amputations in the 80s. They mentioned that when the femoral pulse was the lowest palpable pulse, 71% of amputations were successful, and 18 required an above knee amputation, 11 being refashioned below the knee. So quite big numbers. And so, you know, in the presence of popliteal pulse, there is quite confidence that a below knee amputation will perfectly heal. But what if we don't have a popliteal pulse? هو الدم مش بيتحرك. Since the 50s, it was known that if the popliteal pulse is present before operation, below knee amputation should succeed. The absence of popliteal pulse, however, does not exclude below knee amputation. So the dilemma is present since the 50s. And a common practice is always to evaluate the bleeding from the skin and subcutaneous tissues and the muscle. But is this objective? I think no. In this review here from 1991, clinical judgment alone is insufficient to predict the success or failure of an amputation stump. Many tests like Doppler, segmental pressures, skin blood flow, skin perfusion, all of these has been described to predict the likelihood of successful healing of an amputation stump, but none of them have gained widespread acceptance. Including the tests, systolic ankle pressure have been used, although all extremities with a systolic ankle pressure of more than 70 millimeter mercury healed in below knee amputations. There was no clinical predictive value of indirect systolic ankle pressure measurements. And absolute pressures at the ankle of greater than 60 millimeter mercury has predicted healing of below knee amputations 50 to 90%. Inability to compress calcified vessels with a blood pressure cuff, however, can be problematic and is one of the reasons why this objective test is not always reliable. Transcutaneous oxygen perfusion is another modality. There was a significant difference in the preoperative TCPO2 between the successful and unsuccessful amputations. There were no linear association between TCPO2 and success rate. A TCPO2 of less than 20 millimeter mercury has a high positive predictive value of failure, but higher levels are not 100% predictive of wound healing. Another article here mentioned that a value of more than 40 millimeters correlates very well with healing, and less than 20 millimeter correlates well with failure to heal. The accuracy has been reported to be between 87 to 100%. But there are some limitations for use of this technique. The room temperature should not be cold, and the probe cannot be applied to tissues with edema or infection. Unfortunately, there is no absolute threshold of TCPO2 that accurately predicts healing 100% all the time. Near-infrared spectroscopy, another interesting modality, painless, complication-free, feasible with good reliability. It evaluates other domains than TCPO2 that are more linked to metabolic adaptation. Its capacity to predict stump healing and tolerance to early prosthesis fitting is therefore interesting to estimate, but in future studies. It needs more work and more research to be confident that it's really objective. Let's come now to the more objective testing. The duplex, it can predict the level of amputation. Rates of conversion to higher level of amputation and reoperation were found to increase with more proximal occlusion on duplex ultrasound. Occlusion of only the superficial femoral artery resulted in increased reoperation rate of 50%. Look to the box on the right here. It shows us an interesting information. Not always do we have the same clinical findings like the duplex finding. In their study, 19 of these patients, the popliteal pulsations were documented as not palpable, while the popliteal was open on duplex ultrasound. So this means that when we do not palpate a popliteal pulse, this doesn't mean necessarily that we have absent flow. It could be due to calcification and may mislead, and hence it could be possible to do an amputation in the absence of clinical popliteal pulse. This article here, it's not new, from 2006 by Yip et al. And they studied so many factors regarding the healing, but what I found interesting is the importance of angiographic scoring. They named each segment of the arterial tree, 1, 2, 3, and then they gave a score for each type of occlusion, free or stenosed or total occlusion. And at the end, they made a total score. They found that the score of more than 15 is quite bad. They consider this a cutoff value where they can say above this we should not do a below-knee amputation. This had a sensitivity of 75% and a specificity of 87%. Although the absence of popliteal pulse was associated with failure of a BKE in a bivariate analysis, it was not an independent predictor variable when other factors were considered. It has a positive predictive value of 26% and a negative predictive value of 100%. They concluded that the use of an arteriogram scoring system can correlate well with the outcome, taking into consideration the cutoff value of 15. What about the other demographic findings and the comorbidities? In this article here from 2021, it was found that only hemoglobin A1C level greater than 8.1% was the only variable independently associated with increased odds of reoperation. This article here from 2019 concluded that patients that were ongoing or recent smokers, patients who had diagnosed bleeding disorders, those who require preoperative ventilator use, were transferred in from another facility, were associated with the highest risk of reoperation following below-knee. It's obvious that whenever we have more comorbidities, it affects your outcome. So to conclude, I cannot mention that these are conclusions because these are rather recommendations from the literature and not based on actual research. But we can see that there is no single parameter to depend on to predict successful outcome. Clinical evaluation alone is definitely not sufficient. Studies have demonstrated several objective tools to predict the success, as mentioned, but none of them is totally reliable. Though the studies showed good positive predictive value of these tools, none of these were sensitive and specific enough to depend on as a sole tool to predict the outcome. There are conflicting data about the impact of demographic variables on the success of below-knee, like diabetes, the age, gender, low social standard. This is mentioned by some studies, and the others have said no, it's not affecting the outcome. I have the last slide to show, if I can. So my recommendation or my algorithm of decision making is to see by duplex, do we have a popliteal pulse? If we have a popliteal pulse, So you can proceed to a below-knee amputation. If we don't have a patent popliteal artery, I will look to the angiographic collaterals, whether by CT or by angiography. If there are poor collaterals, I will proceed to an above-knee amputation. If there are good collaterals, here I will be a little bit confused. I will check for the proper glycemic control. Is the patient physically active? Is there anemia or absence of anemia or hypoalbuminemia? If everything is favorable, I would check the bleeding intraoperative and proceed to below-knee amputation. If not, again, I will proceed to above-knee amputation. Thank you for your attention.
Thank you. Thank you very much, Ahmed. Our next talk is by Mr. Martin Arisold. He's joining us online from the UK, and he will speak about should minor amputations of the foot be followed by using prosthesis or not. Do we have Mr. Arisold online now?
Yes, can you hear me?
Good morning, Mr. Martin Arisold.
Morning, morning. Thank you for
joining us, and we are happy to listen to your talk today. Thank you very much.
Are you seeing the screen?
Yes.
Excellent. Well, thank you for inviting me to talk about this subject, which is I had to research a little bit on minor amputations using prosthesis, because it's not something we use in the NHS readily. When we look at the muscles and ligaments of the foot, this is not an anatomy lesson. This is just looking how complex our foot is. And once we take away one component of this major structure of the foot, we start to lose biomechanical function of the foot. And we know this from our observations in diabetic foot population. So this is not a type of device that we use in the UK. We don't use this readily in the NHS purely because we don't know enough about it, probably. Prosthetic devices, are they functional or are they purely aesthetic? I would say initially they're probably aesthetic, but maybe there is a place for them somewhere if we have more research. We'll have a look at that further on. So these are the type of devices that I think people would be looking at, sort of like slip-on devices, almost like a below-knee amputation prosthetic, which is a silicone device. The only issue with these type of devices are they are made of silicone. They do make the feet sweat, and in our diabetic foot population, they may be a consideration of tissue loss, tissue breakdown underneath a hot device like this. So the other issue is the application of these devices may not be suitable for some of our amputations. Most of our amputations are ray amputations, and fitting a device on a ray amputation, the type I've seen, probably would be quite difficult. So we simply use quite a lot of toe fillers. We use a formable Ottoform device here, which is mixed, and then you can form any type of filler that you want in between a toe, or you can buy off-the-shelf silicone devices. And these often are used to prevent toe subluxation, deviation when you have an amputation of a part of a toe. This is quite a extreme example of a hallux abductor valgus foot deformation here, but the toe devices and the silicone devices are placed in between where the toe spaces should be. So there is a place for some type of prosthesis between in a site that's been amputated. And quite often enough, we use custom orthotics for partial foot amputations. So when the patient's healed, we usually send the patient to an orthotist who gets fitted with a device that almost restores function and gait and stability of the foot. These devices distribute pressure, and then they often take up the space where a toe amputation has been, like this first ray or a transmetatarsal amputation. But we know that this is important because, analysis of studies have shown that once you take away the first metatarsal head, you have a massive increase of pressure against the second and then the lesser metatarsal joints. So this study showed that there's at least 60% of the patients had high plantar pressure under the second metatarsal head, which is obviously vulnerable for our neuropathic ischemic type foot patients. So custom orthotics extend further just to not just the orthotic, but to the shoe as well. So you have to have a good orthotic made by a good orthotist, with reduces the pressure, and this type of prosthetic fits inside a shoe. Get this wrong, and you often get the foot, or in this case, transmetatarsal or Chopard foot slipping out of the shoe, and you have to get this absolutely right. And it's important that the prosthetic fits inside the shoe, to a certain degree. So none of these devices really work without an extended shank or like a carbon plate. So most shoes are fitted with a metal plate in the sole, and a carbon plate which allows the shoe to stay stiff without bending where the amputated areas are missing. So without these devices, the shoe would bend at the center of the foot, and you would often get creasing and then forefoot pressures on a transmetatarsal or a toe amputation site. And quite often enough, we put a rocker into the sole of the shoe, which allows the heel to strike and toe off without any bending of the shoe. So the insole is fitted, the device is fitted into the shoe with a shank, a carbon plate, and extended with a rocker bottom to allow the patient to enable gait toe off, heel strikes toe off. So I did think about why we don't use devices like this in the NHS, and like I said before, it's probably related to cost and the aesthetic properties around using prosthetic silicone devices or prostheses. There are some studies that do tell us, and this is really a crude example of a sort of conventional foot prosthesis on the left against a silicone foot prosthesis, which is used in this study. And this particular study looked at the gait velocity, cadence, and length of a patient walking barefooted with a partial amputation of the foot, in this case a Chopard, against a barefooted patient with a silicone device, as you just seen in the previous slide there. And then it was compared again with the patient walking with footwear and conventional prosthesis, which is just a device fitted, an insole fitted in the shoe, compared with the footwear and silicone devices. Now, a comparison between both barefooted and with the experimental type silicone devices showed there was some temporal gait measurement differences or increases within the prosthetic devices, which was slightly significant, statistically significant, which does give some bearing on using a device. But in this particular case, there were only 4 subjects used in this study. So quite a small study again. And then in this study here, there was 56 patients who were recruited using an observational study against a match group and a control group. Only 7 subjects were actually recruited into the study, where they looked at a subject with partial first metatarsal amputation who used insoles, conventional insoles, and other subjects with transmetatarsal or Lisfranc amputation who used fillers and a slippers type socket, against subjects who used Charcot amputation site and a clamshell prosthetic silicone prosthetic device. Now, in these particular cases, the gait of the amputation patient with the first metatarsal amputation was almost comparable to the person without the amputation sites. But there was only one particular case in this study against patients with metatarsal amputation sites were completely compromised when they had a transmetatarsal or Lisfranc amputation. gait abnormalities was significantly evident. And then the patient with the prosthetic device in the show parts did present with some restored function and effective foot length because they incorporated the device actually incorporated a stiff forefoot, supporting the body's amputee's body mass during loading, but not for power efficiency. And in both these studies, they looked at gait efficiency around ankle, the ankle and the hip, and they found that the patients wearing prosthetic devices did actually get a little bit more of a gait efficiency around a slight power efficiency around hip and ankle wearing a prosthetic device, but not maybe significantly enough to suggest it's going to make a massive difference. So in conclusion, really, should minor amputations of the foot be followed by using a prosthetic? I would say there's not enough large empirical research to make an informed decision. There is some evidence of some power efficiency when wearing a prosthetic device, but I would say there's more studies that needed to be evaluated using gait analysis. And then both our research studies here excluded our wider diabetic or vascular compromise patient. So in conclusion, I would say we need some more research in this area, but it's not something we'll probably look into more of in the future, especially as a service as large as ours. Thank you for listening.
Thank you, Martin. Thank you very much for such interesting talk. We were happy to have you with us. Our next talk, Dr. Muhammad Shawi will speak about the updates in the rehabilitation following above knee amputation.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank the board of the DF Care 2022, headed by Professor Dr. Ahmed Taha, for their invitation. Inshallah, we will give a simple update of the rehabilitation of above knee amputees. It's the rehabilitation is actually an educational and problem-solving clinical intervention that aims to reduce the impact of limb loss. So it's about education and problem-solving step by step for these kind of patients. The rehabilitation team to be integrated includes a group of professionals headed usually by the surgical team, orthopedic or vascular surgeons, and including a psychiatrist, and a rehabilitation nurse, an occupational therapist, a physical therapist, social workers, and rehabilitation psychologists, wound care specialist, prosthetist, and last but not least, the family members for psychological support of these patients. Other consultations could be taken from vocational workers, the dietitians, pharmacists, and recreational therapists, and religious personnel. So, concentrating on the overall goals of rehabilitation after amputation, we go through optimizing the patient health status, achieve functional independence for these category of patients, and enhance the overall quality of life. To go through the different physical therapy stages for these above-knee amputees, we have three main stages: the preoperative stage, the post-operative, and pre-prosthetic stage, sometimes split into two, and sometimes combined, because the overall aims are combined. Prosthetic stage is the final stage, and followed by long-term follow-up of these patients. For pre-operative rehabilitation stage, it takes place only, of course, in cases of elective surgeries. It needs psychological preparation and education, extensive education of the patient and their family members to accept and to live with the disability left with the amputation procedure. In the realm of physical therapy, it's a preparatory stage for the post-operative stage, including the required bed mobility transfers, upper extremity and trunk strengthening, and breathing exercises for improving the overall cardiovascular endurance, and learning of post-operative stages of ambulation. The post-operative and pre-prosthetic phases of rehabilitation are an integrated entities, or are two integrated entities, post-operatively, sometimes separated from the point of surgical intervention till the point of wound recovery. And later on, the pre-prosthetic phase takes place when we need to cover the prosthetic training for definitive prosthesis to take place afterwards. The major goals of this stage is wound care, pain management, using different physical therapy modalities, and of course, covered by the medical agents to reduce pain, edema control, and controlling and reshaping the limb, and desensitizing the amputated, the residual limb, positioning and avoiding any contractures that might hinder the prosthetic fitting and the ambulation with the prosthesis later on, bed mobility and transfers, including wheelchair training as a primary mean of transport for these patients early in the rehabilitation, therapeutic exercises focusing on strengthening and stretching and range of motion exercises of the residual limb to maintain it in good shape for prosthetic use, balance training and gait training that will extend basically to the prosthetic phase of rehabilitation to provide the patient with the means of applying or using the prosthesis. Here we can see the desensitization. Desensitization takes place using application of tapping or light massage over the residual limb, and applying soft tissues, cotton balls, or clothes or light clothes, massage in circular way to the residual limb. Applying shrinkers for edema control, reshaping and desensitization requirements, including the fitting of the shrinker, and these are the shrinkers with and without hip support. Then the transfer from wheelchair to bed and the mobility using wheelchair are emphasized, or is emphasized, to allow early ambulation or early out of bed activities. Here the positioning for above knee amputees. Likely the prone lying position is the best to prevent any contractures of the hip. It takes place for, or it's used for a duration of 20 minutes, minimum of 5 times daily. Exercises emphasizes stretching and resistance training to maintain mobility and strength and prepare the patient for gait training and prosthetic training in the later stages. Exercises indicated in these cases are hip extension exercises, taking place from prone or supine lying position, strengthening of the hip abductors from supine or side lying positions, strengthening of hip adductors, sit-up exercises to train the core muscles, especially the abdominals, stretching of the contralateral hip for weight bearing to be very well on the unaffected side, stretching of the hip flexors to avoid flexion contractures, and stretching of the external rotators of the amputated hip. Prosthetic rehabilitation phase starts basically with the early walking aid or the temporary prosthesis used until we apply the definitive prosthesis. Usually it takes us 6 to 9 months to apply a definitive prosthesis when the edema and the size of the limb is stabilized, and the balance training and gait training is done completely. In this stage, we concentrate independent doffing and doffing of the prosthesis, gait re-education, and balance training, progressing to maximum independence with activities of daily living as much as possible. And here we go through some examples of the balance training and gait training, standing between parallel bars, supported and unsupported, weight shifting by using the control from the pelvic point of control. This is shown here, and this is independent or lateral shifts using the from standing between parallel bars. His weight shifting backward and forward. These are side way shiftings, and these are forward backward shifting. Here are some functional activities to be done during balancing, including the forward and above head reaching, and including releasing the pressure from the sound limb, attaining or taking pressure onto the prosthetic limb with support and with shifting from the scapula and shoulder to get much more control on the pelvis and the residual limb while loading the prosthesis. In this stage, we can also make hip shrinkage to make more weight shift onto the prosthetic limb, and here are some training on the ball to control the proprioception of the contralateral limb while taking load or taking weight into the prosthetic limb. And these are steps of gait training, turning around, lateral walking, and anterior shifting. These are stepping up and down stairs using, okay, just a few seconds, please.
Yes, if we can sum up and proceed for the conclusion.
A few seconds, yes, okay, of course. This is getting up and down stairs. Here is some transfers, especially from the sitting position in the ground to standing position independently. Thank you very much. I'm sorry for being lengthy.
Thank you very much, Dr. Muhammad. We're going to move on to our next presentation, and it will be the latest physiotherapies of diabetic foot ulcer by Dr. Hind Abdel Menaim.
Bismillah ar-Rahman ar-Rahim. A special thank for Dr. Ahmed about your invitation. At the beginning, I'm lecturer at the Department of Physical Therapy for Internal Medicine, Cairo University. I will lecture about latest innovation for prevention and management of diabetic foot ulcer. Diabetic foot is one of main causes of morbidity and mortality lead to amputation. It is estimated that one diabetic foot is amputated every 20 seconds. Okay. So our aim for physiotherapy to management of hyperglycemia, bad peripheral arterial disorder, and diabetic neuropathy, which could negatively impact the wound healing process, and the optimization of blood glucose level, which enhance the which enhance healing rate and decrease the risk of ulcer infection and amputation. Even with multidisciplinary approach like daily care, glycemic control, and biotic revascularization, photo flooding, dressing, the chronic ulcer require a long time for healing completely. So many studies looking for therapeutic treatments that can increase the speed of ulcer healing, like epidermal growth factor, hyperbaric oxygen therapy, negative pressure therapy, shock wave, and low-level laser therapy. Today we're talking about low-level laser therapy, which has a different administration, like local laser at the ulcer site itself, and acupuncture laser and laser blood radiation. All of this enhances the healing rate by increasing level of nitric oxide, reactive oxygen species, and improving the regeneration of cell. Also decrease the TNF, tumor necrotic necrosis, Also, recently, there is evidence about laser improves the effect of antibiotic. There are different types of administration for blood laser irradiation, like intravenous laser and extravascular laser. Intravenous laser, which administrates the laser through laser cannula through bacterial, through brachial vein. It is invasive way, expensive, need time, and need expert and need place. But extravascular laser blood irradiation, it is absorption the laser through the blood through intact skin. So it is non-invasive, non-expensive, and easily applicable at home or clinic. Just the laser device applied on the area. The big arteries is very superficial, like a wrist. Our recent studies was to evaluate response of glycemic control to extravascular laser by using laser watch. By using laser watches, semiconductor red laser have a wavelength 650 nanometer, 5 milliwatt power. The duration of session for 30 minutes, 3 times per week, 12 consecutive weeks. Okay, for diabetic patient. Diabetic patient have 5 years diabetes and treated only with oral hypoglycemic medications. The results of this study was there was significant post-treatment decrease in HbA1c, fasting plasma glucose level, oral glucose tolerance test, and also enhancement of fasting C-peptide, beta function, insulin sensitivity, and decreased insulin resistance estimated from home IR. I will focus on glycated hemoglobin because it's important to control glycemic level. The patient, their glycated hemoglobin ranged from 7 to 8.9 milligram per deciliter. The mean difference between pre and post-treatment program was 1.1 for laser group, 0.6 for control group. Also, the effect of laser group, immediate effect of session was 22.7 milligram per deciliter. We measured the blood glucose before the session, and after session, there is hypoglycemic effect of laser immediate post session. For patients which glycated hemoglobin from 9 to 14, the mean difference was 4.2. 4.2 for laser and 1.1 for control group, and the acute effect of laser was 40 milligram per deciliter. It means that more increasing glycated hemoglobin, more increasing blood glucose level, the more increase of therapeutic effect of laser. So, and also there is remarkable decrease in treatment dose of oral hypoglycemic medication after 3 months without a changing of level of physical activity or diet strategies. And it's a main important point. So we can, there is a similarity between the extravascular laser and the intravascular laser in the effect on glycemic control. Other studies, several studies confirm the effect of laser on wound healing. For example, not for count. The effect of laser on grade 1, effect of laser on grade 1 ulcer for more than 6 weeks. After 2 weeks, there was a decrease in the ulcer size and more granulation tissue found. The first picture for control group, there is no difference, and the second and third row for the laser group. At the day 0, after first week, after second week, we can observe the more granulation tissue. Also, the effect of laser for second and third grade of ulcer. These ulcers was resistive for conventional treatment. So the researcher using combined type of laser, using all type of laser, acupuncture laser, low level, local, or and the intravenous laser therapy. Acupuncture laser, local laser use different type of laser. Red laser, 606 nanometer on the ulcer itself and around the margin using infrared laser, 980 nanometer. These are the results. The patient approximately complete 19 sessions for 2 months to convert from grade 3 to grade 1 or to convert complete healing. Conclusion, combined laser and blood radiation promotes the tissue repair process of diabetic foot ulcer with shorter mean healing time of 2 months instead of 3 to 6 months. Recommendation: in light of above evidence, we strongly recommended extravascular laser to prevent and management of diabetic foot ulcer, actually for all ulcers, especially post-operative skin graft operation. We can use laser can be associated with conventional therapy or advanced therapy, especially human growth factor, 3D bioprinted innovation, mesenchymal stem cell. Recently, the mesenchymal stem cell can be reconditioned by biomodulation in vitro and then in vivo. It will give a significantly improvement in healing rate of ischemic infected ulcer. Ischemic infected ulcer, and it is the main cause for amputation. We hope to open a new angle of vision to reduce rate of limb amputation. Take home message: don't ignore your diabetic foot ulcer. Thank you.
Thank you, Dr. Hind. Thank you very much. We came to the end of our talks today, and we'll proceed now with the discussion. I've received so many questions. الحقيقة أنا زي ما كنت متوقع وكلمت أحمد قبليها، هو 90% من الأسئلة للتوك بتاعت أحمد، عشان it was very interesting talk لينا كلنا الحقيقة. It's very debatable topic و very interesting. فهنبدأ ببعض الأسئلة اللي جت للدكتور أحمد. بسم الله. One of the question by Dr. Mahmoud Salah: if no popliteal pulse, any chance for retrograde revascularization at the same session? I mean يعني ساعات احنا بنفتح وبنشوف ان ال vascularity is not that good, is not promising. At this point, do you take a decision to go for a retrograde revascularization from the popliteal artery مثلا وبعد كده نحاول نعمل البيلوني amputation ولا؟
I don't have this experience, but I remember well Dr. Mahmoud presented a few cases based on this concept. They were quite interesting and challenging and successful. We saw all the images of the process of healing. So I really support this, though I don't have my own experience about it. So it's interesting to maybe conduct research about it and a little bit change in the current evidence about the below-knee stumps.
هو it's very interesting دكتور محمود بيه الحقيقة الموضوع ده ما اعرفش يعني حضرتك in your experience how many cases have you done such an intervention?
Actually, we did some cases after we do the amputation, and you have 3 stumps, anterior, posterior, and peroneal. Any one of them you can use as an axis, put a sheath, try to revascularize the popliteal artery. It gives very good results. How many cases? I guess we did something between 10 and 12 cases like that.
Great. Nice.
Great.
But maybe it will need the setup of doing an amputation in an angio suite or a hybrid or with a C-arm, maybe because usually we do
on the OR table, just using the C-arm.
Great.
Just be prepared for this, because usually when you do amputation you don't have things beside you. But if you are prepared, you can do it easily.
بس هنقول للعيان يدفع كام بقى كده
Thank you, Dr. Mahmoud. Another question by Dr. Tamer Fikri. We always talk about the below-knee amputation rehabilitation versus the rehabilitation of the above-knee amputation. So what about the through knee amputation?
I believe.
I think, Dr. Tamer, you meant not only the rehabilitation. I think the function of the stump later on and the effect of.
I believe it has a better functional outcome, though
better than معلش.
than
the above.
The above knee.
Okay.
Than the above knee. Though we are quite hesitant to do it. We all know it's a good procedure. It's quick to do, and it has good healing. And at the beginning of our career, we used to say we don't have the appropriate prosthesis, so we shall not proceed to something like this and leave the patient without a prosthesis. But currently, the companies are promoting that they have these kind of prosthesis. I really encourage doing this, though I don't have a big series of such patients. Actually, all what I have done was always as an emergency where we were not able to do a proper below knee amputation, so a trans-knee amputation was faster, but I cannot depend on this as a general recommendation.
Another question by Dr. Amr Abu Rahma. What about the intraoperative state of bleeding? يعني bleeding during the operation. Is it a good parameter? I think في مننا كتير بيعمل الحكاية دي. يعني بيعتمد على إنه ما فيش popliteal pulse and he's pushing his luck زي ما كنت بتكلم مع أحمد الحقيقة قبليها. موضوع below from above is a big difference الحقيقة بالذات في بلد زي بلدنا. لأن المحاضرة الحقيقة بتاعت الدكتور محمد شوقي كانت جميلة جدا إن هو وضح لنا ان الموضوع مش موضوع بس هيلينج ومش موضوع فيزيوثيرابي وفاسكولار سيرجري، لا ده محتاج سايكوثيرابي ومحتاج كوميونتي. It's a big community problem. Is our community able to handle this problem ولا لا؟ ده موضوع اكبر مننا الحقيقه. مش عارف مين بيتكلم دلوقتي. مش عايز ارد. فموضوع ان احنا نبوش اور لاك في موضوع الليفل اوف امبيوتيشن انا متهيألي انه مهم جدا، حتى لو ما كانش عندنا بوبليتيال بالس. حتى الموضوع ده is very important بالذات في بلاد زي بلدنا. العيان اللي هيبقى عنده above knee amputation he will have at least يعني باكثر التعبيرات تهذيبا he will have a very hard life later on. فاحنا بندور يعني الحقيقه بنتلكك بندور على اي حاجه تخلينا نجستيفاي ان احنا نجو فور below knee.
Clinical judgment of bleeding is one parameter that can tell us about it. But my message is that it's not the only parameter. We cannot solely depend on the clinical judgment, and that's why I try to figure my ideas about this in an algorithm. To mention that there are some situations you actually don't need to depend on the bleeding, like when you have a patent popliteal artery by imaging. So I don't care so much about the bleeding. But when it's equivocal, yes, the clinical judgment by bleeding is important. But I cannot say from the start I will depend on this alone. And having an occluded popliteal artery, having poor general condition, no. Bleeding could be good and misleading. Like any diabetic food deprivement, when you do it in the first day, you find excellent bleeding, and 2 or 3 days later, the patient comes to you for follow-up, and you find it's a little bit ischemic. It's the same, but it is one of the parameters to be depend on when everything else is equivocal.
طيب الحقيقه so many questions جايه لنا على التوك بتاعت دكتور احمد، ويعني مش هنقدر ندسكست كلها، لكن to sum up انا I'm يعني coming up with an idea ان احنا نعمل زي some form of poll كده. مين من حضراتكم بيلتزم بالبوبليتيال بالس as a level for his amputation؟ كام حد فينا يعني يا ريت بس الموافق، يعني هل اللي بيرفع ايده معلش عشان افهم، لو ما فيش popliteal pulse بيبروسيد directly to an above knee amputation؟
يعني خلي الفريزنج ان لو ما فيش pulse يبقى all the time above knee.
افندم ما انا بقول اهو ايه اللي بيعتمد على البوبليتيال pulse for the level of amputation. يعني باختصارا كام واحد لو ما لقاش popliteal pulse هيبروسيد directly to an above knee amputation؟ يعني I think 2 or 3. So it's أنا I agree with the majority الحقيقة. أنا الحاجة الوحيدة اللي ما ببقاش فيها ملتزم قوي بالأورثوذكس بوك يعني هو ان انا الليفل اوف امبيوتيشن. موضوع فعلا اكبر من موضوع، هو ما هوش ميديكال بس، موضوع كوميونتي بروبلم. الريهابيليتيشن موضوع كبير جدا، مش بس فيزيوثيرابي. اتذكر يعني الواحد كان فتره لما كنت شغال بره، الحقيقه الموضوع الريهابيليتيشن كان فيه عيانين بتفضل قاعده في المستشفى لمجرد ان هم بيغيروا السلالم بتاعه البيت عشان العيان ما يتصدمش لما يروح بيته ما يعرفش يطلع السلم. موضوع كبير جدا. احنا هنا كبلد وككوميونتي مش هنبقى قادرين نكوب وذ اللايف ستايل بتاعه العيانين، ولذلك بيلوني امبيوتيشن في رايي المتواضع يفرق كتير جدا عن الاباف ني. I would agree مع الدكتور احمد ان احنا في بارامترز كتيره جدا، لكن احنا as much as we can we'll try to push our luck and I think chairpersons مش عارف.
I think if you follow
متهيألي كلنا متفقين على كده، نبوش اور luck شويه في
I wouldn't mention as pushing our luck because if you follow some rules you actually
rather than
have
populate.
evidence.
يعني
Yes,
it's
yes.
not like just a luck، لكن ان احنا نعتمد على parameters تانية، ندور على اي parameter promising ان احنا يسمح لنا نعمل بيلوني amputation. Thank you very much يا احمد. في one question الحقيقه للدكتور احمد شوقي، لا الدكتور محمد شوقي اسف. هو الحقيقه question from دكتور احمد طه، وانا الكويستشن الحقيقه عجبني جدا، انا كنت عايز اساله الحقيقه. التايم اللي should يعني time lag اللي should be taken between the healing of the stump of the above knee لغايه لما نقول العيان is ready to wear a prosthesis and walk، تقريبا التايم الايديال او الكويس.
اوكي حضرتك بنتكلم على definitive prosthesis، بنتكلم from 6 to 9 months.
6 to 9 months
for definitive prosthesis، مش بس عشان الهيلينج، عشان كمان الستامب شيبنج والسايز. السايز ان هو يبقى يعني
والماسل سترينث لو
وبقيه البارامترز في الرينج والماسل سترينث طبعا يا دكتور. ففور definitive prosthesis عشان يبقى ده الفاينل شيب، سواء كان اكزوسكيلتال اندوسكيلتال وات ايفر التايب اوف prosthesis to be used، هنحتاج from 6 to 9 months.
يعني التايم المقبول من 6 to 9 months. طبعا it can differ between according to the age مثلا وcomorbidities والحاجات دي.
definitely.
طيب لو compared بالبيلوني، نرجع لنفس الموضوع ده، التايم فريم بقى بتاع البيلوني.
التايم فريم more or less the same for definitive prosthesis، ولكن نقول ايه المعدل النجاح اعلى في البيلوني،
لكن 6 to 9 months. يعني انا بالنسبه لي البيلوني دي بالنسبه لي 6 to 9 months الحقيقه يعني مش astonishing، بس احنا دايما بنقول للعيان او يمكن بنهون عليه، بنقول له شهرين ثلاثه وان شاء الله هتبقى ماشي وبتاع. يمكن
لا يو ار رايت دكتور، هو هيبقى ماشي، لكن definitive prosthesis is the one he will use for life يعني. لكن temporary prosthesis او
ان هو يقدر يقوم ويتحرك independently
looking aid pylon shaft and that way، لا احنا بنتكلم من 1 to 1.5 months he can use it once the initial edema is subsides and the suture is well closed and loading mechanically
والمصل edema subside
فبنتكلم within range اقل من كده بكتير على temporary prosthesis for initial training. So he can accept load on the stump as early as 1.5 months maybe, but it's temporary. It's changing in the socket size. Of course, it's using pressure wraps and compressions to control any further edema with loading.
الحقيقه دي نقطه تانية مهمه جدا، موضوع التمبرري ديفايس والبيرمننت ديفايس، لان ريجاردنج الايكونوميكال ايشو العيان البردن بالذات مع النيو برايسز بتاعت البروثيسز، العيان هاردلي كان افورد. الحقيقه نتكلم على اغلب العيانين بتوعنا هي هاردلي كان افورد وان بروثيسز، ده هو يعني الحقيقه لو جيت قلت له ان انت بعد شويه هتغير المقاس، دي بتبقى مشكله دايما احنا بنشوفها في انا اسف دكتور احمد طه كان هي نفس ال
اوكي. timber can be used
هل نقدر
for long طبعا timber can be used for long.
how long we can use
لا we can use it as long as it doesn't wear, it's fine.
4-5 سنين مثلا
ما فيش
على ما ينسى
على ما ينسى الالم بتاع الاولانيه الالم اللي حصلت من التكلفه بتاع الاولانيه. it can be used but the final one is more stable size wise and it's usually the finishing the external appearance, the aesthetic appearance is better.
تمام.
That's
Thank you very much
Like we can keep with the temporary for long.
Thank you very much.
You're welcome.
A question by Dr. Hisham.
Yes.
طيب تفضل.
Comment only for the blue knee amputation. زي ما حضرتك قلت, not only social problem, but we do as a research for the patient energy expenditure for the patient doing above knee and blue knee. The results is the patient doing blue knee amputation is less than 5 folds energy expenditure than the patient doing above knee. فدي لوحدها
طبعاً.
كفيله بان احنا تاني حاجه بالنسبه للبوبليتيال بالس, احنا بنعتمد على البوبليتيال بريشر والماسل تيرج بتاعت الماسلز اوف ذا posterior aspects of the
cuff muscles.
بالظبط cuff muscles. If it is good we do blue knee amputation. فدايما احنا حريصين على مساله الريهابيليتيشن بتاع العيان حتى في حياته بعد كده, والبروسيسز بتختلف كتير جدا. فدي يعني my comment على الموضوع ده.
Thank you very much. Because we are running short of time, we'll have to move on with the next section. Thank you very much. Thank you for all the. Thank you.